all had an insightful and inspiring first day and ready for yet another day filled with learning and meaningful discussions. To start the day, we have 12 free papers to present. I would like to request Mr. Kaviraj Khanal and Dr. S. Pauline Arokia Catherine to join the scoring panel. In order to introduce our panels, Dr. S. Pauline Arokia Catherine is an experienced speech-language pathologist with over 11 years in teaching, research, and clinical practice. Passionate about empowering communication, she has guided students, published research, and led parent and professional training programs. A former associate editor of the Journal of Indian Speech and Hearing Association, she continues to inspire excellence in speech and hearing sciences. Mr. Kaviraj Khanal is Technical Director, Speech and Hearing and Unit Chief of Audiology and Speech Language Pathology at Tribhuvan University Teaching Hospital, Nepal. With over 30 years of experience in clinical audiology, speech language pathology, and rehabilitation, he has significantly contributed to advancing hearing and speech sciences in Nepal. Mr. Khanal is an advisor to Speech and Hearing Association of Nepal and Nepal Stuttering Association and a past president of SAN. His professional interest includes voice therapy, auditory verbal therapy, and orally hearing intervention. Over to you, Sarang ma'am.
Scientific presentation now. I'd like to call upon the first presenter, Birangana Wagle, to present a topic on comparative evaluation of acoustic voice quality index and dysphonia severity index in professional voice users.
Evaluation of acoustic voice quality index and dysphonia severity index in professional voice users. So to diminish the risk of voice disorder in those individuals, voice screening or vocal analysis is important. Where generally acoustic analysis and aerodynamic measures are used to assess the voice quality. But acoustic voice analysis is considered as one of the standard methods in clinical practice. Where acoustic voice quality index and dysphonia severity index are widely used tools to quantify the vocal quality. Even though they are widely used, but their comparative effectiveness has not been evaluated in Nepali-speaking professional voice users. Moving on to the aims and objective, this study aims to compare the diagnostic accuracy, clinical utility, and correlation of ABQI and DSI with perceptual and subjective assessment in Nepali-speaking professional voice users. The objective of our study are to obtain ABQI score for Nepali-speaking professional voice users, to calculate DSI scores in the same group of participants, to compare ABQI and DSI scores in terms of their ability to represent overall voice quality, to analyze the relationship between ABQI, DSI, perceptual voice assessment, and subjective self-evaluation questionnaires. Moving on methodology, this is a cross-sectional analytical observational study. A proposed sampling method was used to collect the data of 30 professional voice users between 20 to 50 years of age and more than 1.5 years in profession, where there were 10 teachers, 10 singers, 9 SLP and 1 RC. The recording tools used were flat software and ABQI script. Each participant completed a series of phonatory tasks like sustained phonation, connected speech, maximum phonation duration, pitch glide, and soft phonation. The indices computed were ABQI and DSI. Pearson correlation was used to analyze the relationship between ABQI and DSI, where Spearman correlation was used to check the association involving SPHI. Williams test was used to check the strength between the relationship between those variables. According to this table, ABQI and DSI has a strong negative correlation. It means that higher the acoustical impairment, lower the physiological vocal performance. And ABQI and DSI both were significantly correlated with SPHI, and ABQI and SPHI has moderate positive correlation. It means, according to this scar plot, if the value of ABQI increases, the value of PHI also increases. DSI and SPHI has moderate negative correlation. It means that if the value of DSI increases, the value of BHI decreases. Even though both ABQI and DSI are significantly correlated with SPHI, DSI has a strong correlation confirmed by the Williams test. To discuss the results, the finding demonstrated that objective and subjective voice measures are significantly related. Both indices were correlated with SPHI, but association was stronger for DSI. Hence, DSI may serve as a more sensitive indicator of perceived voice handicap, while using both DSI and ABQI provides a more comprehensive assessment of vocal quality. To summarize everything, ABQI, DSI and SPHI together provide a better overall understanding of vocal quality in professional voice users. ABQI also shows potential as a prognostic indicator in hyperfunctional voice disorder requiring minimal voice samples. This study highlights certain limitations of ABQI when compared with subjective rating scales, and it also recommends the importance of test batteries. Here are my reference. Thank you. The voice problem, we collected the data of those person who doesn't know that they have the voice problem. If they have any problem in their vocal cord, and
They were just professional voice users, they didn't have any issues.
no.
Maybe I think we should take a group with the voice problem to analyze the scores, either with the two measures that you have taken, right? DSI or the other one. What is that?
ABQ.
ABQ, yes. So then it will show whether it is really measuring their issues, the acoustically, whether it can correlate the findings well. Maybe next time when you continue the study, maybe we suggest that you continue with the voice disorder population.
We compare it with voice handicap index.
Yes, because they will not have any issues, right?
No, they feel like they have issue, but they didn't know that they have any dysfunction in their vocal cord. So we are evaluating that part.
So you are evaluating their problem. Have you informed them whether they have problem, or they only say I have problem in my throat?
No, according to BSI, we calculate
So
that part.
The topic is knowledge gap in dysphagia, a study among nursing students in Nepal.
I am Ms. Nancy, audiologist and speech language pathologist from Pokhara Academy of Health Sciences. I am going to present our study on knowledge gap in dysphagia clinical condition with some serious complications like malnutrition, dehydration, reduced overall quality of life, or even death. Nurses are often the first professionals who observe these swallowing difficulties in hospital settings among inpatients, which places them in a critical position for early identification. The role of nurses in dysphagia includes, but is not limited to, dysphagia screening, providing feeding assistance, maintaining oral hygiene, making appropriate referrals, and providing counseling to the patients. However, these roles will only be executed properly if they have adequate knowledge to support the dysphagia care. Previous studies conducted in Nepal and other low-resource countries like Namibia explored the knowledge of dysphagia among practicing nurses and found that they had moderate level of knowledge. However, there are no studies to date that explore this knowledge at the training level. This led us to investigate whether nursing students are being adequately prepared to handle dysphagia cases in their future careers. In addition to assessing the knowledge levels, we also explored whether the knowledge differed based on the age of the nurses, the type of nursing faculty they are enrolled in, and any previous exposure to dysphagia patients. A descriptive cross-sectional study was conducted in Maharashtra's nursing campus. Using a complete enumerative sampling, we recruited 206 nursing students from bachelor level. We included students from two nursing faculties, Bachelor of Nursing Science BNS and Bachelor of Science in Nursing BSc Nursing. The mean age was 22.37 years. Knowledge was assessed by using 30-item dysphagia knowledge questionnaire developed by Andrea Pickleboy 2015, which covers signs and symptoms, complications, and management domains. The overall average correct response rate was 61%, which classifies as a moderate level of knowledge. The correct response rate for signs and symptoms was 66%. Most of the students identified the overt signs and symptoms like feeling of food getting stuck in the throat or weight loss, but only 9.2% of the participants agreed that not all aspirating patients cough, indicating a gap in knowledge of silent aspiration. Similarly, the average correct response rate for complications was also 66%. Most of the participants identified the respiratory complications like choking and aspiration, but only 17% could distinguish dysphagia from digestive issues, indicating frequent misassociations with gastrointestinal issues. The knowledge of management was weakest at 51%, where almost 77% of the participants agreed to avoiding thickened liquids to dysphagia patients. Only 50% recognized the need to refer to a speech-language pathologist, and 25% agreed that feeding tubes are only indicated to unconscious patients. We used chi-square test to assess the association between the factors. We found that older students and students of Bachelor of Nursing Science had significantly greater amount of knowledge. This is likely because of the greater or longer experience in the field, as the students of PNS have already completed a 3-year certificate level nursing course and require a minimum of 1 year of clinical experience before they enroll in their field, but BSc nursing students do not have such experience. Similarly, we found no association between prior dysphagia exposure and the level of knowledge, which indicates that passive exposure is not enough and structured education is essential. However, that point also brings me to the limitation of our study. The item prior dysphagia exposure was measured as a yes-no response without assessing the duration of exposure and their level of involvement in the patient care. So, exposure may not have reflected true clinical learning in our study. To conclude, nursing students demonstrated a moderate level of dysphagia knowledge, and a significant gap exists in management knowledge, particularly regarding the use of NG tubes and referral practices. These poor knowledge of management results are consistent with findings from Nepal and Namibia among the practicing nurses. Similarly, in the previous study conducted in Nepal, 82.6% of practicing nurses reported that they are not satisfied with their knowledge on dysphagia, and all of the participants stated that they would like to receive further forward training. Thus, it is important to incorporate former dysphagia modules, simulation-based nursing, simulation-based training, and interdisciplinary collaboration with the speech-language pathologist in the clinical rotations, continuing education programs targeting dysphagia management to ensure that nurses and nursing students are adequately prepared to handle dysphagia in their careers. Thank you. Included students from first year through fourth year.
Okay. Right. So maybe your fourth year alone you could have taken their knowledge might have been, or you could have divided them into as groups, first year, second year, separate groups. If you have compared, you would have known how their knowledge would have improved.
Yes, ma'am. We included A's, but yeah, retrospectively that would have been
Yeah.
more suitable.
Yeah. Otherwise, a very good try.
Nursing from only one college or?
Yes, sir.
Yeah.
Right now we have included, we did convenience sampling among the nursing colleges.
Because facilities are not available in the other hospitals.
Okay.
Yeah, that is a problem. Okay. Thank you. Good presentation.
Thank you, sir.
The next presenter is Anjali Srivastava. Her topic of presentation is investigating the association between acid reflux and dysphonia in patients with voice disorders.
I'm Anjali Srivastava, BSF intern from Maharashtra's medical campus, and today I'm going to present on topic investigating the association between acid reflux and dysphonia in patients with voice disorder. Introduction. Reflux is the stomach content backflow into our throat, and the dysphonia is refers to the alternation in voice production and that interferes with social and professional communication. And my study highlights the impact of reflux on voice disorder patient, which is often overlooked condition in the clinical setup. And the objective of my study is to investigate the association between acid reflux and dysphonia in voice disorder to determine the severity of dysphonia in patients with acid reflux. This study is a survey-based study with sample size 45 participants, and I have used the PHI and RSI tools to collect the data, and the data analysis was done by using, I have done Pearson's correlation to find out the association between reflux and the voice impact. And I have included patients with voice disorder and also coming with a complaint of gastritis, and I haven't included the patient having neurogenic voice disorder or speech language disorders. In the analysis part, these are the descriptive analysis of the age of the patient, and the correlation analysis shows that there is a strong correlation between reflux symptoms and voice handicapped index. And I have also analyzed the severity, and the result shows that reflux, due to reflux, the severity in the voice disorder increases if complaint of acid reflux is present in the patient. And the present study show a strong positive association between the reflux severity and dysphonia, indicating that increased reflux symptoms lead to greater voice impairment. And the findings from the previous studies are, most of the studies have shown that there is a strong correlation between RSI and PSI, and also SOBT and exercises have improved the quality in their voice of the patient with both the voice disorder and the reflux. And the limitation of my studies, we haven't used any objective analysis part like pH monitoring or anything else. We have done it through the self-reported questionnaires only, related with the symptoms similar as the patient having a vocal nodule and the adduction caps, but they feel more chest pain and their hoarseness level is a little bit more than the normal.
Okay. So what would be your recommendation? You have seen so many clients, right? So what did you recommend them?
As we don't prescribe any medicine, so we counsel them from the dietary modification part also, as reflux is present over there, and we make necessary referrals for them so that they will get multidisciplinary management. And in most of the patients, we have seen that improvement takes place better in the case of multidisciplinary approach.
Thank you.
So, have you judged how much reflex is there? Any idea from the EMT?
No sir, I have used the reflexivity index and
Okay.
from that only if the score is greater than 13 then reflux is present over there. If the scoring is less, we haven't used such.
Okay, thank you.
You used SOVT as a treatment
No,
option?
sir, I haven't used that. That's from the another study.
Okay.
They have mentioned that if they use that, that improvement has been seen.
Okay. As a clinician, I want to ask you that question. See, how do you think SOVT can help in a case with acid reflux induced voice disorder?
In the studies, it has shown that due to reflux, there is due to the pepsin in the throat, vocal cord is disturbed and they apply more force to speak. So SOVT, due to the relaxation, by using SOVT, they feel further.
Yes, thank you.
Craniofacial anomalies and laryngeal rehabilitation. He holds a PhD from Manipal Academy and Higher Education MAHE and has published in high-impact Scopus Index journals including Springer Nature IF 7.86. Dr. Ahmad has received multiple national and international Best Paper Awards and established the first Speech and Hearing Institute in Northern Karnataka. He is currently developing a new medical college-based speech and hearing institute at STM University. We have pleasure to have you in our panel, sir.
Inviting Mr. Shivam Kumar Maji for the topic, a longitudinal analysis of speech rhythm in a native Nepali-speaking adult with stuttering, pre and post instrumentation changes using the pairwise variability index.
Come for the presentation on the topic of longitudinal analysis of speech rhythm in adult who stutters, pre-intervention and post-intervention changes using the pairwise variability index. There are my co-authors, Prasidika, Mamta and Sabin Sarmadawadi, my supervisor. These are my table of contents. So, starting with the fluency disorder characterized by disruptions in the timing and rhythm of speech. Rhythm reflects the temporal organization of speech, the pattern of duration and pause between the syllable. So, starting rhythm gives an insightful motor control and fluency mechanism. PVI is an acoustic measure of speech rhythm that quantify the durational variability of successive syllable or vowels. RPVI helps us to, RPVI is used for the consonantal intervals and MPVI is for the normalized or vocalic interval. So higher PVI means more durational variability and irregular rhythm. But in the English language, the high PVI, they already have the high PVI. That doesn't mean they have all of them have stuttering. So low PVI have the less variability and more regular rhythms, improved fluency. So the rationals of my studies are individuals who stutters often saw slightly high rhythmic variability compared to the fluent speakers. Pairwise variability index is a tool that quantify the rhythm by measuring the durational variability between successive syllables. Few studies are Muthre in 2017 and Delvo in 2008 also did the same, and they also have the pre and post intervention rhythmic changes using PVI. Hence, there is no any rhythmic research done till now in Nepal. So this one is the primary. So objectives of my studies are to analyze the speech rhythms using PVI in adult who stutters, to compare the pre-intervention and post-intervention rhythm patterns, to determine whether the fluency therapy results in the reduced rhythmic variability. The aim of my study is to analyze, compare the speech rhythms of adult who starters before and after fluency intervention using the pairwise variability index in order to determine whether the therapy leads to improved rhythms, regularity and fluency. So methods, so I take the 5 participants who came for the therapy, in seek of therapy in TUTNs. 2 of them were stutterings and 3 were mild, serious. 2 of them were severe stuttering and 3 of them were mild stuttering. The mean age was 31.8 and the duration, it is depend on their satisfaction, like 4 or 6 sessions of therapy. Data analysis was done by SPSS and Sapiro-Willig test for normality and pair t-test for testing the differences. The procedures were recording the spontaneous samples in a quiet rooms by standard protocols. Segmentation in the BRAD software, calculating the segmentation and estimating the RPVI and NPVI. So by using the BRAD software, we can do the analysis by acoustically on the first image, and by mathematically we calculate the pairwise variability index of NPVI and RPVI by using that formula. So result were like pre-intervention the mean was 34.03 and standard deviation was 2.8, which thus decreases in the mean like 29.21 after post-therapy, and standard deviation will increases like 3.01. It was for the raw PVI, and normalized PVI pre-intervention was 45.61 and standard deviation is 2.87. Post-intervention were 40.17 and standard deviation were 4.41. And after t-test, there were the significant changes in both normalized and raw PVI. These were my SPSS analysis. So discussion RPVI value of pre-intervention and post-intervention were 34.03 and 29.1 respectively, and NPVI value were pre-intervention and post-intervention were 45.61 and 40.1 respectively. So post-intervention reflect the PVI indicates improved rhythmic regularity and better timing control of speech. Findings suggested that fluency therapy enhances the temporal coordination and of speech production in adult with stutters. Result assigned that with the previous study showing that rhythmic becomes more consistent by the following structures fluency based intervention. The study support the uses of PVI as an objective measure to marker of fluency improvement. Clinical relevance were objective assessment of fluency. The pairwise variability index provides a quantitative measures of speech rhythm allowing the clinician to objectively evaluate the fluency changes PVI percentage judgment. Monitoring the therapy sessions like pre and post, we can use the PVI and RPVI to whether there is significant changes or not. Supported like evidence-based practice. The PVI is an standard tools for to change it, to measure the rhythmic regularity. The guiding the therapy purpose, finding emphasize the importance of rhythmic timing and control the fluency therapy, encouraging the clinician to include rhythmic-based training intervention plans. Conclusion reflects the fluency speech rhythms measured through the PVI serves as objective indicators of temporal controls in adults with stutter. Therapy improvement, rhythmic regularity, quantitative evidence of progress, and clinical research and future scopes where further we can use in the lab samples and follow up to see more and long-term rhythmic changes on the cross-sectional linguistic comparison. Thank you. These are my references. 2 of them were severe stutter and 3 of them were mild stutter.
What technique was used? No, what was the technique used? We have touching,
sorry,
right?
sorry,
What
sorry.
technique was used? And pre and post.
So starting shaping, fluency, modified airflow, okay, and then prolongation, fluency shaping.
So all of them received all the techniques?
No. We use holistical approaches to, according to the patient, we make therapy plans.
Please show me, what was the result of the Shapiro-Wilk test? What was the value, p-value? Did you find a p-value for Shapiro-Wilk's test? Before you decided to go for the t-test, did you find a normal distribution?
Yeah.
Because your sample size is 5.
Yeah.
I'm a little doubtful there. Shapiro-Wilk's test, initially, you did to find out whether there is normalized distribution, correct?
Yeah.
After that you went for t-test.
Yeah.
I want to see the p-value of the Shapiro-Wilk's test. Do you have the data?
Forgot to mention here, but
You should mention it. One. Because if you do not have a normalized distribution, you should not use t-test. You should go for a non-parametric test. Okay. And your sample size is 5. I'm really doubtful whether if it is less than 0.05. In Shapiro-Wilk test, if it is p-value, if it is not less than 0.05.
yeah, there is p-value, sir. There we have.
That is t-test value.
T-test,
I'm
yes.
talking about the Shapiro-Wilk test.
Okay.
Go to your methods, you have mentioned it there. Okay. So this is for your understanding because you need to display that as well. After that, whether it is a normal distribution or not, going for a parametric or a non-parametric test, that decision should be taken. Okay, because your sample size is very low, I'm a little doubtful whether did you get that way. And what Madam asked the question, it's a very right question. You did not have a comparative, therapeutic platform. So whenever you do such cases, especially if you have such, pre and post therapeutic, please make sure that the therapy was given similarly across the patients, or you make two groups and give, one set of therapy to one group, another to another group, and then make a comparison. Otherwise, you do not have a platform to compare. Okay, this is just for your information.
So we only use the how pre and post therapy changes can be we done.
Correct, but the therapy is not similar across your patients.
Yeah, but
so see, one person gets one type of therapy, another person gets another type of therapy, fourth person gets another type of, all of them have different kinds of therapy. How can you see pre and post? What are you trying to compare? So you cannot put everything under one group. So be more specific when you do that. And remember, normality. Okay, please. Thank you.
The topic of my study is cross-linguistic rhythmic patterns, pairwise variability index in native Nepali and Nepali speakers. These are my agenda. So rhythm is the pattern of timing in speech, which makes the speech more natural. And languages around the world are classified as either as syllable timed, stress timed, or mora timed language. Impairments in rhythm can be seen across different speech disorders and language disorders. Stress timed and syllable timed language. In stress timed language, stress syllables are roughly placed in equal intervals, and in syllable timed language, all the syllables have roughly equal time interval. English, German are stress timed language, and Nepali, Hindi are syllable timed language. So pairwise variability index is a quantitative measure to measure the rhythm of speech, and it works under the principle that rhythm is reflected within the vocalic and intervocalic time duration of the speech. Nepali language is the official language of Nepal, and 44.6% of the population in Nepal speaks Nepali. It is originated from Indo-Aryan branch of language family. Nepali language is spoken by 3.19% of Nepal population, and it originates from Tibeto-Burman branch of language family. My aim is to investigate cross-linguistic rhythmic patterns between Nepali and Nepali speakers using pairwise variability index, and my objectives are to calculate raw and normalized PVI and to identify if the languages are stress timed or syllable timed, and compare the rhythm patterns of both languages. We used 20 participants were involved in this study, 10 native Nepali speakers and 10 native Nepali speakers. For the procedure, we recorded the spontaneous speech sample of the participants in Pratt, and we marked the boundaries using Pratt text grid. We noted the segment duration, and we calculated the NPVI and RPVI using the formula. Data analysis was done through SPSS. Normality test was done using Sapir-Whorf test, and independent t-test was used. So we recorded the sample and we marked the boundaries using Pratt like this, and we calculated the PVI using these formulas. So the results show that raw PVI mean was 30 in Nepali and 39 in Nepali, and mean and PVI value was 43 in Nepali and 42 in Nepali language. Based on Sapir-Whorf test, all the distribution were in normal distribution. There was no significant difference in the Nepali and Nepali language, rhythm of Nepali and Nepali language. That was P value was more than 0.05. These were the analysis, and P value was more than 0.05 in Sapir-Whorf test as well as independent t-test. So these values suggest that both Nepali and Nepali are syllable timed languages. More studies have been done on Indo-Aryan languages like Hindi and Konkani, where both of them are syllable timed language, and other studies have been done on Tibeto-Burman languages like Mandarin and Cantonese Chinese, and both of them are syllable timed language as well. So clinical implications. The transfer of therapy can be done across the language, both languages. Application of assessment tools can be used in both languages as similar. Through this study, we can set a normative data of both Nepali and Nepali language, and therapy can be focused on emphasizing the timing of syllables in the therapy in both languages. For bilingual speakers, generalization can be easy if the skill is obtained in one language. It can be generalized to next language. And unified pacing framework, syllable timed syllable timed therapy approaches can be more applied. So to conclude, both Nepali and Nepali had similar type of rhythmic patterns. They both are syllable timed language, and for the further studies, we can use different dialects of the languages, and also we can see the effect of one language on next second language in bilingual speakers. These are my differences. Thank you.
Was it a conversation task or a narrative task or a reading task?
It was not a reading task. I asked them questions to just like give me your introduction or tell about your own town, and they gave me.
So the narration, they just read. Okay. Fine. Do you think there will be a difference in a narration task versus a reading task?
I first tried in reading tasks as well, and they were similar.
Let's go back to a reference slide. So just wanted to give a suggestion. Whenever you mention references, please give the year as well, and try to follow the format. Okay, because tomorrow when you become a scientist, somebody gives you a reference and you see it there on the screen without a proper formatting, it breaks your heart. So second thing, these two languages that you just mentioned, they come from different civilization based. This one, I'm just asking you, this is not related to your study, just from my personal interest I'm asking, because one is Tibeto, this one Burmese, and another one is
Indo-Aryan.
Yes, exactly. So now, do you feel that you did not see any difference with your PVI indexing, but dialects, do you see is there a difference there? Like for example, if I see Kannada speakers who are southern Karnataka speakers coming to northern Karnataka, there is a stark difference between the two. Like that, do you see a difference perceptually? not with related to PVA. If you listen to them, do you feel that there is a difference in rhythm patterns?
Yes, I feel that in eastern parts the rhythm is different, and in western part rhythm is different. In Nepali language also, I used pattern dialect, but October dialect is different. Perceptually I feel that.
Very good. So my suggestion is you should go deeper into that. And also, as Madam said, reading task and a speaking task, the rhythm is going to be different. You record your own speech, okay? When you talk or you narrate and then you read, you yourself will have different dialects because you are trained to read in a different way and you are practiced to speak in a different way. So this is a good study. This can go a little bit more further. We are just trying to give you more suggestions. Go deeper into this. Try to see with the dialects, not only is the PVA, but the other rhythm analysis parameters as well, and then you will come up with even more data, I'm sure. Okay, good.
Thank you, sir.
The next presenter is Shivani Karki. Her topic is on a qualitative case study, tracking the evolution of generative language in a Nepali speaker with Lucas Apesia post-Venus.
I'm Shivani Karki, BSMP third year student. My study is titled Tracking the Evolution of Generative Language in Nepali Speaker with Lucas Apesia post-Venus. These are my agenda. So Lucas aphasia is a non-fluent aphasia where speech becomes effortful and broken. Individual usually can understand what's being said but can't form full sentences. So therapy here mainly aims at correct word use and constructing sentences. That's why Venus works here. Broca's aphasia limits a person's ability to express themselves. So this study looks whether word networks could help them reveal sentences naturally. Word network strengthening treatment. So VNest is a semantic-based therapy which helps people find words with their related meanings. Words are connected with their related nouns like who does what, which helps them sound natural and meaningful. Practicing it every day generalize in daily life communication with longer sentences and meaningful sentences. It uses verb, agent and present structure. So my aim is to evaluate the functional outcomes of VNest in native Nepali speaker with Broca's aphasia, analyze changes in mean length of utterance, word diversity, production of complete argument structure in spontaneous discourse. This is a single case pre-post comparison. Our participant was 47-year male diagnosed with Broca's aphasia due to ischemic stroke. We used narrative sample about the Safe Festival before and after 6 weeks of Venus therapy. So during baseline assessment, his speech was non-fluent. He produced incorrect grammar and incomplete argument structure, meaning he rarely produced complete agent present verb structures. He had short and telegraphic utterance. So therapy began with these verbs. We choose the verb and patient was instructed to build agent, present and verb structure. From three pairs were selected, and from that one pair was selected, and he was asked WH question. Across the session, he recalled that verbs, he repeated the steps, and he resolved the sentence he produced, and he was instructed to produce sentences independently. His speech was transcribed as exactly as spoken in Nepali, and we compared samples on MLU, word diversity, well-formed sentences. So after therapy, his fluency was relatively improved. He could form more complete sentences. Quality-wise, he could form flexible and natural sentences, long sentences. And quantity-wise, his MLU and verb diversity was increased. This is a comparison of pre and post therapy. So before Venus, he had short sentences with limited verbs and missing grammar, but after therapy, he improved quality-wise as well as quantity-wise. So VNest works because it strengthens word networks, activates related words. In conclusion, VNest improved sentence length, verbs and argument structure. Therapy which works on verbs led to generalization, showing functional improvement that needs in daily life communication. These are my references. Thank you. 1 week, 1 session, so 6 weeks. 1 week, 2 sessions, so 12 sessions.
12 sessions. So how long he was having aphasia? He was having Broca's aphasia, right? This is how long he was having?
3 months.
3. It's a very good study. Nice to know that VNest really works. I think we should do on more subjects.
So I'm happy to see a single case study being presented, because single case studies have their own value. Many a times we always try to see that you need to have a larger data to say that there's an evidence or not. Personally, if you ask me, I have been always a fan of single subject designs, because single subject design itself has so many things to do. So these kind of studies give you an analysis of that person. Definitely may not be a bigger evidence, but if I put it in one sentence, absence of evidence is not equal to evidence of absence. That means you have seen a difference in that case that has made a change in that person's life. You may not be able to put it together into a larger data and then present it like how the empirical data will require, but still you have made a change. So single subject design students should never feel that I've done a single subject design, it is just one subject design. No, a lot of things go into that. One more suggestion for you, go back to that pre and post slide that you had put. You can go for many more parameters there. Next time when you evaluate, see, you're trying to see mean length of utterance, total verb tokens, unique verb types, but VNest goes a little bit more beyond. Okay? When you're talking about mean length of utterance, how many words added, how many arguments connected, but you can also try to see how much is the richness of the syntax, whether it is automatically coming. For example, tenses, gender markers. Okay? Sometimes you may not have triggered it personally, but it may start generalizing and improvising. So you can evaluate that and also see. So try to see other single subject studies, understand how well you can portray the data, reanalyze your data and see, you will find many more information. Okay, good study.
Now I would like to call Sabin Sharma Davari. His topic is whole word analysis score in children with speech sound disorder.
This study is a part of my PhD thesis as per the data of my PhD thesis. So my PhD thesis is on development of a test battery for screening and diagnosis of phonological disorders. So speech sound disorder is one of the most common impairment in preschools. It reduces intelligibility, affects participation and academic readiness as well, and conventional segmental analysis focuses only on individual phonemes and misses the broader phonological organization. We have a lot of other measures as well. That's why we are developing a test battery encompassing all those skills. Need for measures the whole word level performance to understand the child's phonological capacity. So whole word indices here, in this study what we discuss about is the phonological mean length of utterance, percentage of word proximity and percentage of words correct. So phonological mean PMLU is we first add up all of the words and then we add the each segment of a word, that means a consonant of a vowel, we give the score 1. We obtain the total score and again we add the total number of consonants. That's how we get, and we divide it by the number of words. And PWP is how close is PMLU to the target word, and percentage of word correct in terms of the percentage. So in the Nepali language there are certain study which deals about the correct consonants, vowels, but this sort of whole word analysis, there's always a research gap in the literature of Nepal. So Ingram, it was introduced by Ingram, PMLU, so he introduced it as to quantify phonological complexity and proximity, and also other researchers, other literature review, they also say it's clinical utility in that can be used again to add all the information and based on different theories of phonology, it can be used in the assessment and screening. So this study aimed to compare the whole word performance between Nepali speaking children in SST and TDC, typically developing pairs. So we just, our objectives were to analyze and compare these scores and do the analysis of this, and can this be used for diagnosis or screening or not. So method, it's a comparative case control study. So how we prepare the stimulus for is, I use the stimulus prepared for the thesis for this study. We selected some most common words, like they were in the initial, that it sound, we developed the stimulus of initial, medial and final position, validating it. And we selected a professional artist, and we made him draw the pictures, and we validated it as well. That's how we made it ready, the stimulus ready. And the task was, we showed the task pictures to the children, and the children had to produce the word with that. We went to the different schools for that, preschools for that. So here for this study we have 10 Nepali children aged 4 to 5 years. 5 of them are typical pairs and SST groups 5. So we also improved our ethical clearance for this. And procedure which I have already discussed. So typical pairs consistently outperform SST pairs on whole word measures. So typical pairs produce longer, more complex and more accurate word forms. SST pairs showed simplified word structure and reduced accuracy. So these are the scores. So that data met the normality assumptions. These are the value of survivable test. And also there was a variance. We did the Levin's test. That's why we did Wells test after that, post that. And the power was a bit, the sample size is very low. So also we also have done the Man-EU test for that effect. So this shows that there were significant differences across all the measures. And because the sample size is extremely low for this, and the effect size HB and this delta value shows that there are robust differences between the two groups despite we use very less sample size. So typical pairs had greater phonological complexity, SST pairs reduced phonological organization. So finding supports the clinical sensitivity of PNLU, PWP and PWC for Nepali children. So these findings are supported so our findings also support the other studies of Ingram and 2002 and and Ingram 2006. So this is a very, it might add into the diagnostic test that we might use for the holistic phonological profile of Nepali children. And we had a small sample in this, still we are in the process, just like a pilot sample. So we are also developing some tools like where we have the proper sensitivity, specificity value, ROC curve. This is just a starting of that. So later we are also planning to develop this on that track. So yes, it can be used. Thank you, sir. Inclusion criteria of SST was when I went to the schools to screen children where we suspected the errors as per the screening, like informal screening and other tasks, and we called them to the clinic and did the comprehensive evaluation and we diagnosed as SST.
So what's any inclusion criteria you follow?
I'm sorry, I didn't say the inclusion criteria. Age group was 4 to 5 and they were native Nepali speaking children. We did the informal hearing assessment, we did the whole motor test as well, and all the structures and function finding, and it was not the phonological errors were not the function of any structural, sensory or hearing, other things, and it was a developmental condition that we first made sure before we included it into SST group.
So the measures that you have taken, PMLU and PWC, can you just explain about it? How did you go about it?
Phonological, it was given by Indra. It's a measure of whole word analysis. So PMLU, phonological mean length of utterance. For example, we have a word cat. So we have phonemes at. So but there are two consonants. So here we say we give the score. First we give the score for all the segments at, that is 3, plus correct consonants. Correct consonants, and has to be correct. If both are correct, it's 3, 4, 5 will be the score. So if is wrong, if he says cat, then we only give 4 score, because first adding phonological segment, number of all segments plus number of correct consonants. So that way, and PWP is the child's PMLU out of the targeted PMLU. So that is PWP that way. And percentages, like we are calculating the correct total number rather than the bottom up. There are certain top-down approaches as well. We have core vocabulary approach, like just stimulating directly by the word. Sometimes these approach also, and also like cycles approach, these type of approaches where
Language-based
approaches.
Thank you.
Metaphone approach also, when we implement it from the whole word and top-down way.
So I was interested in that pictures that you were talking about.
Yes.
So what was the stimulus? Picture stimulus that you developed?
Picture stimulus was for like for ka sound. We have 3: initial, medial, and final. We first made the list of the words, and we asked 3 SLPs to validate that, and when SLPs validated, and we obtained the set of the words from ka 3.
So you mean to say you were depicting nouns there in the pictures?
Nouns. Mostly there are nouns, but in Nepali there are certain phonemes like ja. There are no nouns when ja is in between, like we say majeko, that is brush. So that case we use verbs, and the pictures are also action words. And otherwise,
predominantly they are nouns or verbs?
Pardon, sir?
Predominantly
there are nouns.
Okay. Now for validating these pictures, did you use any psychometric scoring?
We just use this Likert scale, like familiar, most familiar. That way we validated with 3 SLPs for the pictures as well.
Okay. But I would strongly suggest,
Yes.
because your data is dependent on that picture, okay, you need to look into psychometric analysis of pictorial stimuli.
Yes.
Okay, so when you look into that, there has been a lot of work that has happened. Okay,
Yes.
especially starting from 1980, Snodgrass and Vanderwaart. If you see this picture set, the first time they gave a set of parameters that can help you decide whether this picture can be used as a strong stimuli, moderate level, or it is a poor stimuli. And you need to balance your stimulus set that way, so that your further data doesn't get affected. So I strongly recommend that if you still have time, you please do, that requires name agreement, image agreement, okay, familiarity rating, complexity rating, and a few other, that is frequency rating or TOT. There are many more parameters that you can choose, but at least these 4 parameters are of paramount importance: name agreement, image agreement, familiarity, and imageability or imaging.
Thank you very much, sir.
Okay, yeah.
Thank you.
Again, I would like to call Kriti Keshi. Our topic is the translation and validation of eating assessment tool EAT10.
To people having difficulty in swallowing through translation and validation of eating assessment tool EAT10 in Nepali. Let me start with a picture we have all seen in our clinics. An elderly man sitting in front of a bowl of rice hesitating. He lifts the spoon, and before that spoon even reaches to his mouth, the daughter quietly removes the plate. She is afraid that he will choke again. Moments like this, quiet, everyday, but deeply painful, are where dysphagia silently steals not only nutrition but dignity, confidence, and social connection. Now, imagine in this same home in rural Nepal, we want to assess dysphagia, but the assessment tool we rely on, the ITIN, is not in his language, not is in his context. That exactly where this study began. Dysphagia is difficulty in swallowing, resulting from abnormal oral phases of swallowing. Eating assessment tool is most widely used assessment tool to assess the severity and impact of dysphagia. And until now, there is no validated assessment tool that is available in Nepali context. For any assessment tool to be used in another language, there needs a cross-cultural adaptation to ensure the linguistic accuracy and psychometric properties. The primary objective of my study was to translate, culturally adapt and validate the ITIN for Nepali-speaking population. We aim to ensure reliability and construct validity for clinical and research application in Nepal. For this, we followed a rigorous process. We conducted a cross-sectional study among 60 patients with dysphagia and 40 healthy people. And translation validity was done by forward and backward translation and expert panel review, and reliability test was done by calculating Cronbach alpha and Pearson's coefficient. Now, let's look at the most interesting part of this presentation, that is results section. The chart shows the different diversity of the clinical reality. We included all the neurological and hedonic conditions in our research. And here we can see that the Cronbach alpha value we got was 0.899, which falls under the good internal consistency. The item risk correlation was 0.134 to 0.777, which shows the good internal consistency. The Cronbach alpha, if item deleted, also shows excellent internal consistency, and inter-item correlation shows moderate to strong positive correlation. The discussion part, the Cronbach alpha of Nepali version was 0.899, which is comparatively closer to the original version, that is 0.96, and other validated tools in other language such as Spanish 0.87 and Italian 0.93. Hence, Nepali E10 exhibits high internal consistency, linguistic cultural equivalence with the original scale, facilitates improved clinical identification and cross-cultural research in Nepali context. So next time we meet that hesitant elderly man or that young stroke survivor afraid to eat, let's remember that assessment is the first act of empathy. And now with the Nepali E10, that empathy finally speaks their language. Thank you so much for your time. These were my references. Thank you. In our hospital, we look patient in wards also, in our OPD also, and the patient mainly referred to us was oropharyngeal dysphagia patient. Their diagnosis was that, and we included only those patients.
Okay. Did you see any other difficulty when you give clinical trials? Do you give them any food to assess?
Yes, ma'am.
Yeah. Can you tell about it?
Yeah, those things are not included in my research, but in our clinical practice, we do ITSI test, giving in different consistency of food to the patient and doing clinical trials.
Okay. Now, what are any other difficulty? You said oral pharyngeal dysphagia, right? Yes. So, what kind of difficulties they had?
They have the difficulty of mainly swallowing, but other difficulties like licking of food. Leakage of things.
Okay.
So, you mentioned correlation coefficient, Pearson's.
Yes.
I did not see it in the results.
Yeah, I just mentioned the value, but did not.
What was the interpretation?
Sorry, sir?
What did you infer from the correlation statistics.
I didn't get you.
You have mentioned Pearson's correlation coefficient in your methodology.
Yeah.
You did not mention it in the results. So what was your interpretation from that statistics in your study?
That it has all the values were positive and it was strongly correlated. That was our interpretation.
You should mention it.
Okay, sir.
Avanti Jaur. The topic is on impact of screen time in language acquisition in children.
I am Avanti Jaur here to present on the topic impact of screen time in language acquisition in children with and without language delay, a cross-sectional study. Language is the primary medium through which children expresses and understands ideas. In recent years, however, there is much more increase in array in screen time among young children. Studies suggest that too much screen time may lead to poor language outcomes, but the extent of the study is unknown and varies with different factors. The main objective of our study was to evaluate the association between screen time and speech and language developmental milestones. Especially we aimed to determine how both receptive and expressive language skills were affected. Methodology: we conducted a comparative cross-sectional quantitative study involving 200 participants of up to age 7 years. We used a non-probability purposive sampling, and for the data management, SPSS version 27 was used. The inclusion criteria included Nepali children speaking aged up to 7 years, children with normal hearing, and children whose parents are willing to participate. The exclusion criteria included Nepali children aged more than 7 years and with hearing impairment and syndromes, children whose parents are not willing to participate. The study variables included dependent variables include language developmental skills, receptive skills, and expressive skills. The independent variables included age, gender, screen time duration, age of screen introduction, types of screen, screen content types, and co-viewing status. The assessment tools used were receptive, expressive, immersion language scale Wheels 4, and self-developed questionnaire. And the results were in group A, the age less than 3 years were 53, and in group B 28. In group A, age greater than 3 years were 47 and 72 in group B. The diagnosis of the group A were AST. The children in group A had AST. 67% of the children had AST, 16 had language disorder, 10% had GDD, and 7% had other kinds of language delay. And in group B, the children were normally developed and had typical speech and language development. The receptive age of group A were less than or equal to 36 months was 91% and greater than 36 months were 9%. In group B, receptive age less than or equals to 36 months were 28% and greater than were 72%. The expressive age of group A were less than or equals to 36 months 99% and greater than 36 months 1%. Less than or equals to 36 months for expressive age in group B were 28% while greater than 36 months were 72%. The graph shows children in group A who were enrolled in school and their screen presence or absence of screen at school and home, their own screen and speech stimulation during the screen time. The pie chart shows duration at school were 48.6%. The pie chart shows the children with up to 2 hours screen duration were 48.6% and above 3 were 51.4%. Likewise, in group B, the screen duration at school up to 2 hours was 57.8% and up to 3 hours was 42.2%. And the screen duration at home for group A up to 2 hours was 48% while more than 3 hours was 52%, and for group B screen duration at home up to 2 hours was 89.8% and above 3 hours was 10.2%. We did a multivariate regressional analysis. This analysis showed that as the screen time increased, the language performance decreased in those children, and children enrolled in school and who does not children enrolled in school are less likely to have speech delay compared to those not in school, and children who does not use screen at school have lower risk of speech delay than those who did. Children who own their own screen are about 4.6 times more likely to have speech delay, and children introduced to screen before 2 years and over 6 times are more likely to have speech delay than those exposed after 2 years if parent interacted and talked with the child during the screen time, the risk of speech delay is reduced. Our findings in the discussion part, our findings align with several recent international studies. For example, there was a significant correlation between excessive use of screen time affecting speech and language acquisition of children, which was given by Hussein A. Children exposed to more than 4 hours of screen time per day exhibited a significantly higher prevalence of speech delay. Screen time more than 2 hours daily increased the risk of speech delay 6.2 times in children. In conclusion, our study found a significant association between increased screen time and speech-language delay in children up to 7 years, and children who use screen without co-viewing or interactive engagement were at a higher risk. These findings strongly reinforce the recommendations made by the AAP, American Academy of Pediatrics, and WHO to avoid screen exposure for children under 2 years. Our result highlighted the importance of parent awareness and responsible screen habits to promote healthy language development. These are my references. Thank you.
Questions? Any questions?
Thank you, sir. Thank you, ma'am.
Next speaker, Kriti Kesi. Topic is translation and pilot exploratory study of behavioral pediatric feeding assessment scale in the Nepali population, normal versus children with autism spectrum disorders.
I am Kriti Kesi from Maharashtra's Medical Campus, and today I am very excited to present on translation and pilot exploratory study of the behavioral pediatric feeding assessment scale BPFAS in the Nepali population, normal versus children with autism spectrum disorder. Before beginning, imagine this for a moment. A mother sits in a clinic holding her 4-year-old son. Her voice trembles as she says he hasn't eaten a real meal for days, only biscuits. Every meal time ends in tears, gagging, pushing food away, crying until he vomits. For others, the feeding is maybe just nurturing, but it isn't just nurturing anymore. It's a heartbreak. And this is the reality that inspired our study to create a Nepali version of BPFAS so we can better understand and support these children and their families in our cultural context. Feeding difficulties are commonly seen in both typically developing children and children with autism spectrum disorder, and BPFAS is a widely used assessment tool to assess the feeding behavior problem in these children. And until now, there is no validated tool in Nepali version. And for any assessment tool to be used in other language, cross-cultural adaptation is crucial, ensuring the linguistic and psychometric properties. The primary objective of our study was to translate, validate, and check the reliability of the questionnaire. We aim to compare the feeding behavioral issues in normally developing children and children with autism spectrum disorder. For this, we followed a rigorous process. We conducted a pilot exploratory study which included 113 EST children and 36 normally developing children. We did translation by forward-backward translation and expert panel review, and reliability testing was done by calculating Cronbach alpha and Mann-Utley test. Now, moving into the most exciting part of this presentation, the result section. This chart shows the differential diagnosis with gender distribution, where our sample has mostly AST children, male AST children comparing to the female. And the Kronberg alpha of our translated version was 0.830, which is good internal consistency, and mean feeding problem score p value was less than 0.001, showing that the AST children has comparatively more feeding behavioral problem than the normally developing children. And in the discussion part, the Kronberg alpha of our Nepali version assessment tool was 0.830, which was comparatively closer with other translated versions and original version of BPFS. Hence, with our study, we concluded that the BPFAS ensures the high internal consistency and is linguistically and culturally equivalent with the original scale, and autistic children exhibit comparatively more feeding problems. And this study provides the foundational evidence for future large-scale validation of BPFS, and this study also emphasized the need for culturally and informed feeding interventions in the Nepali context. These were my references. Thank you so much for your time.
What does it indicate? What kind of problem is that? Is that a motor issue or a sensory issue?
It mainly shows sensory issues.
What did who constituted that panel decided?
Thank you for the question, sir. In our panel, we included 2 SLP, 1 audiologist also, and plus 1 linguistic.
Why not a nutritionist or any other person? Because you're talking about feeding here. Yeah. Why not an OT? Why were they not there?
In our, very good question, sir. I also thought about it, but in our tertiary care hospital where we work and where this study was conducted, we didn't have OTs, so we were unable to include them.
Whenever we are talking about the panel, if the relevant professionals are included, that is better. One. And why did you use Mann-Whitney U-test in your statistical procedure? You mentioned Mann-Whitney U-test. What was the reason that you selected a non-parametric test?
Thank you for the question, sir. I really thought about it before also, but right now I don't have any answer for this question. I'll sure get back to it.
You don't have to think about it. You have to just do another test to find normality, okay? So
okay,
next time. I think the statistician would have done that. You should report it.
I would like to request presenters and co-authors to receive certificates from Mr. Siva, chaired by Dr. S. Pauline Akriya Catherine, language pathologist with over 11 years of experience in teaching, research and clinical practice. Deeply passionate about empowering communication, Dr. Pauline has guided numerous students, published impactful research and led training programs for both parents and professionals. She has also served as the Associate Editor of the Journal of Indian Speech and Hearing Association and continues to inspire excellence in the field of speech and hearing sciences. Over to you, ma'am.
Thank you for the good introduction of me. Okay, we'll start the first guest lecture for the day. I invite Ms. Shabnam Fatima, MSA SLP, from Advanced Hearing Practice Practitioner and Rehabilitation Manager, Clinical Support, Medal, India. Shabnam Fatima is a speech language pathologist and rehabilitation manager at Medal, India, specializing in hearing implant rehabilitation for adults and children. Based in New Delhi, she has trained over 250 professionals and 1,000 students since 2014 and supported cochlear implant programs across India. She holds a master's in speech language pathology from Ayush Mysore and is pursuing her PhD on adult rehabilitation at Aston University, UK. Her interests include auditory development, adult hearing implant rehabilitation and professional education. A warm welcome to Ms. Shabnam Fatima to to give a guest lecture.
Which is, I think, is kind of relevant to anyone who's working with children with any kind of hearing device, be it hearing aids or cochlear implants or any other kind of middle implants. So the crux of today's presentation is on how do we make it easier for children with cochlear implants to learn language and to develop listening skills and eventually develop intelligible speech. Next slide please. Can you please change the slides? I have grouped the strategies into 3 categories. I will initially talk about what the strategy is and then how to use it and why do we use it as well. How we are going to do this is we're going to try to make it a little interactive, because what I understand is that a lot of you all have not worked with children with cochlear implants, at least not in a therapeutic setup, right? So we will try to make the next few minutes a little bit interactive. So I've categorized the strategies into strategies that we generally use to get the child ready to listen, so that the child develops language and listening. And then we have the listening strategies, and then we have the talking strategies. So when we talk about this getting ready strategies, it's not strategies that we as therapists should do before the session. Rather, we have to kind of make sure all these 4 strategies or resources that you're going to use in the session, these 4 strategies are catered to. Open, ears on. Okay, it's very simple. The thing is, whatever the child sees, we are going to talk about. But when we talk about it to the child, the device should be kept on. But that does not mean that the device should be on only during the session. The idea is the child has the ability to listen all throughout the day. Okay. So yesterday, if you guys were there in the symposium, I emphasized on how research really points out to the importance of the wearing time, right? Which we calculate using the hearing hour percentage. So this strategy caters to that part of it. So which means as a team, which includes both the implant audiologist and the therapist, they keep in mind that the child device is ready, there is no issues that needs to be sorted before the child starts listening through all waking hours. So when I say waking hours, what do you think the waking hours is about? What do you mean? What is waking hour for you? Yes. How long are you awake in a day? Roughly? 14 hours. 14 hours, yes, okay. So that is probably kind of ideal. Yeah, 14 plus 8 if you calculate. Do you sleep for 10 hours in a day? Or 11 hours in a day? Right. So the idea is, apart from the time that the child is sleeping, we want the child to be using the device. Of course, when the child is taking bath, we do make sure the device is not on. But otherwise, any other activity, the device is there. Okay. And even sometimes when you ask children who have used devices for a long time, they prefer to wear the device and wake up, because they want to hear their parents coming in and waking up, or they want to hear the alarm going on in the morning and things like that. But for the initial stages, all waking hours is a general guideline. And again, yesterday I think I showed you research that tells us that is a minimum of 8 hours, and the ideal is anything about 12 hours a day. Okay. So yes, another thing, strategy that we think about when we are getting the child ready is making sure we are at a distance where the child is able to hear us, and this we call as the come close to me strategy, right? We want to make sure, especially if the child is a unilateral implantee, okay, we want to be on the side of the device always when we are talking. Of course, you might think, oh, does that put the child at a disadvantage? Yes, of course, on the non-implanted side, the child is going to be at a disadvantage. But again, our idea for children in the initial stages is that the child is picking up as much language, listening to as much as rich language and speech input that's there in the child's environment. So it's always advantageous to be on the side of the implant. And so who are the people who is going to be talking to the child during these initial stages? Immediately, I think more it's going to be the parents, right? The mother, father, and if it's a joint family kind of a setup, you have the grandparents, you have the siblings, you have the extended family who's going to be there. So these strategies, again, when you're thinking about, it is not just something that you tell the parents alone, but it is something that the family who are interacting with the child is very well aware of, that when they want to interact with their child, they stay closer to the side where the implant is, and that's why it's called the come close to me strategy, right? Now, why do we do this? Okay, so one of the things that is there, I think I can say this about Indian environments, is we are very noisy people and we are conditioned to kind of interact and learn in the noise. We don't make a lot of fuss about it, right? But for a child with cochlear implants or hearing implants, this has to be kept in mind, because we want to make sure the child is getting a clear input when someone is talking to the child specifically or playing with the child. And the other reason is the distance. Okay, I'm not an audiologist by practice, but I do see audiologists here, or some of you who have practiced audiology, right? How much dB do you think kind of loss is there when you increase the distance from, say, let's talk about 3 feet distance? How much loss do you think? This hall is relatively very quiet, where I think if I talk from here, right? How many of you all can hear me without making a lot of effort? I think even till the end you can? Yeah. You can? Okay. Okay. But there is a loss. You do understand that, right? Yeah. As to what Pauline ma'am is going to hear versus the last person in the hall. So what do you think is the dB loss from here to there? I think it's, you are at a distance of 6 feet. You are probably at a distance of 15 feet or more. If I'm not wrong, my distance is not very great, right?
Maybe 20 to 30 dB loss.
20 to 30 dB loss, yes. Yeah, maybe. So how do we calculate this? Okay, there is a formula. Alright, so when you increase the distance from 1 feet onwards, when you double it, okay, you add 6 dB to every time you double, right? You've heard, there is actually research to this, but this 6 dB loss is what is considered, okay? And what happens in the 6 dB loss is that, of course, because you guys, she knows probably what I'm talking about, so she's trying to put it. But if that was a child sitting there, there'll be a complete information loss, because the child may not know what I'm talking about. I only have PowerPoints, okay? So we want to minimize the effect of distance, that 6 dB loss that happens for every 3 feet and onwards. We want to reduce that, right? And of course, provide a very clear signal as much as possible. So, and then the other thing that you have to remember, say there's a lot of background noise happening, like yesterday evening, the cultural night, say that was happening right now, okay? You will again be missing a lot of information that I'm talking, even though I'm using a mic here, right? Especially if, say, that noise, I'm sure it was about 100 dB, yes, if I'm not wrong, yeah. And what I'm talking is now probably around 70, no, I'm not 50, I'm using a mic, I'm 50 now, probably, but now I'm probably 80, 70 dB, okay. So when I'm talking in the mic, you will be able to hear me, but when I'm not doing that, you're going to have again information loss, okay. So the general rule of thumb is the signal should be 30 dB above the noise. Okay, these days you have a lot of apps on the mobile phones which you can download and measure the dB that is happening if you're in the therapy setup. And what we also do is we give an awareness of this to the parents just to get an idea of what kind of environment they are in a day-to-day basis. We don't know where they are living, right? They might not be living in such a quiet place. They might be living in a very busy part of the city or alongside the traffic, right? So having that awareness and telling the parents that if they think the noise is higher than what they are talking, then they have to make some arrangements, like be close to the child whenever they are interacting with the child. Okay. So what all can you do in this under this strategy is you move consciously, you move closer to the child, okay, on the side of the implant, you lean in. If the child is obviously smaller than you, you pick up the child, okay, and you make sure you use if it's a therapy setup, you use a proper therapy setup with a high chair or something like that, so that the distance between your face and the child's device is not very far. But that does not mean you have to sit kind of like ear to ear, put your heads together. It's just that you have to be conscious about this, and the minimum distance that we say is 1 feet, which is very good for the child to get all the information, right? Now, I don't know if you already thought about it. So when I'm talking about this come close to me strategy, you might also think, can't I just be louder? Can't I just scream? Yeah? Can we just not scream to the child or talk loud? I don't have a louder voice. My voice is very thin, very soft anywhere. So anyone has to use the come close to me strategy. But some of you might have a loud voice versus a soft voice. So again, the idea is that when you are increasing the loudness of your voice, there is going to be a certain information loss that is going to happen, okay? And also for the person who's speaking, it's a big trauma to their vocal system, right? And we don't want that. We don't want the families to get used to shouting at the child to get the child's attention and things like that. So instead, this strategy is highly recommended. Right. So the other one is called the reduced background noise. Okay, I just talked about it. Why am I reiterating this again? So you guys have heard about how sound gets reflected across and refracted across reverberated across the different materials that are there in a room, right? So let's take example of this room. What do you think? Is this a room that is very conducive for therapy? Do you think the child will be able to hear everything well, considering the materials around you? Think of the floor, think of the door, think of the open door, think of the walls, think of the curtains. No, right? What do you think is happening? There is probably a lot of reverberation, right? Even when I am speaking, because of the system here, you can hear a mild echo that is there, right? Which is very mild. Okay, for us, it's not making a lot of intrusion. There is no information loss. But for a child who's beginning to hear, this kind of a setup in itself is going to be something that is not going to allow the child to take in a lot of information. So why do we apply this? Not to all the auditoriums in the world, to the therapy setups, to the homes. Okay, the therapy rooms should have less material that is actually reflecting the sound to reduce the echo that happens because of reflection, and a lot of materials that reduces reverberation also, again because that also leads to information loss. So then what materials do we use? We use materials that absorb the sound, okay, it does not cause those things. So what do? We use materials like a carpet, right, thick curtains, and doors that are not like shiny like a glass. In a lot of setups that I walk into, to make it all fancy these days, the therapy rooms, doors are glass, okay? And what happens, why? Because they say, oh, the parents can see the child from outside, okay? But again, it's very counterintuitive, okay, for the child, or counterproductive for the child, because that glass first of all is going to distract the child, And secondly, it's going to cause a lot of reflection around, and the child is not going to hear the quality well. So wooden doors with stoppers, with probably, I don't know what it's called, but something that a layer of material in the ground is very, very important. The doors, the windows should be completely locked. If it is not, there's a gap or something, you should have a sealant or some material that is covering that, right? The idea is not to make the place dark and dampy and dungy. The idea is to make the place fun, at the same time conducive for listening, okay? So what you have to remember as a rule of thumb is hard is bad, soft is good when it comes to listening for it, okay? So the next strategy is the same thinking place strategy. This I'm sure all of you all know, right? The thing is, you guys would have learnt about the communication triangle, right, in speech therapy classes, as to why it is very important that what we are talking about, what the child is looking at and listening to, okay, and what is present in front of the child should all be aligned. So that's why we call it as a triangle, and this strategy is an extension of that. So when it comes to listening and learning, we say that whatever the child is thinking about is what we should be thinking about, or vice versa. What we are thinking about or talking about is what the child should be thinking about and looking at as well. Okay, so when the child sees aeroplane, you say, oh, see, there's an aeroplane going on, right? So if there is a mismatch, what happens is that, of course, the child is not going to respond in a way that you want the child to respond, and also the child is not going to learn what you want the child to learn. Okay. So how do we do that? Similar to the communication triangle, you always follow the child, and more importantly, you always follow the gaze of the child. Where is the child looking? Okay, what is the child? Because whatever the child is looking at is what probably the child is also thinking about. They might not have the words for it, which is why you are there as therapist. You are giving the words for it for the child to learn. And also the gaze is an indirect indication of where the child is paying attention, which means the child is ready to learn whatever you are going to talk about. So this is why this is very, very important strategy. Okay. Now you guys might also think, okay, is it, or you might have come across research that says like, what if the child is only learning what is immediately there in front of the child, right? More often than not, what we see is children are learning only the immediate functional words or vocabulary that the child has been exposed to. Or we have this question as people who are assessing the child, does this child even know what we call as the abstract language? Okay, so there is another technique for that, there is another thought process for that. But again, when you think of this technique, think about children who have been recently implanted, specifically children less than 2 years of hearing age or listening age. Okay, so now a couple of listening strategies, and this is where the fun begins, okay, of you guys interacting. Right? So the first one is talk, talk, talk. I'm sure the therapist sitting here might be thinking, is this parallel talk? Is this self-talk? What talk is it? Right? So this, yes, this combines both parallel talk and self-talk. Okay? The idea is we are in a situation or in a setup wherein we are able to talk to the child more. Okay? But the idea is also that we provide as many words as possible that the child can hear. The child might not immediately respond to with all these words, but it's, if, I don't know, 10 years back when I started going into this field or working with this field, the therapist used to talk to the child only in words, point to this and it's flower, or it is white, or it is light, or just short phrases. Now the idea behind this technique is we talk to the child in full complete sentences, like how we will talk to a child who is of the same hearing age, right, or chronological age, sorry. same chronological age. So we are going to give the same advantage that the child's peers are getting. Okay. Now what do we have to remember here? One is we have to think about what we call as the conversational turns. Okay. So what happens, and you guys might also see, or for example me, I'm a very verbose person, okay, I talk a lot, like how I'm talking here, but luckily you are here to listen and I'm talking, but more often than not what happens is that when I'm sitting with the child, I get carried away, okay. So the thing that I have to remember when I'm using the talk strategy is, there is good turn taking between me and the child, okay. And going a step further from this, okay, we think about what is called as the length of the turns. Okay, if I am talking in a sentence that is of 4 words long, I should give the same amount of time for the child to take a turn with me for the same length of words. So it's not just the conversational turns, okay, number of turns, okay, it's also the length of the turn that I have to keep in mind. So when I'm going to skip to the next technique. Okay. Okay. So I think I combined it here. Okay. So what happens is when I'm taking a turn, most probably in the initial stages, a child who's been recently implanted will not have the same length of turn, right? If I'm going to say, oh, there is a red dog outside the door, right? The child might not say, yes, I see the red dog. The child might just say dog. Okay. Now what do you do for the remaining period of time? You give that pause to the child so that the child is like, you don't talk during the child's turn, even though the child is only returning back one word. You pause, you give some, pause, the same length that you are giving, and you expectantly look at the child. Okay, indicating to the child that you're expecting the child to probably talk more, okay, and then you can build up the conversation from there. So, when can you do or how can you do the talk? Of course, we all know any and every activity that the child is involved in can be taken up for this strategy. One thing that I want you all to remember is, when you're using the talk strategy, you don't use questions. You only use statements. Okay? Questions automatically indicates to us that we are waiting for the child to answer. Now that puts a lot of pressure on the child. Now we don't want that. So we only use phrases that are not questions. This is also a little bit fun, acoustic highlighting. We'll do a small exercise, okay, just to wake us a little bit up for the remaining sessions. Okay, acoustic highlighting, I'll tell you the definition and you guys can use one word where you can acoustically highlight. Now is that we want the word that we want the child to pay attention to more highlighted. Okay. Now, how do we do this? We can do it in 2 ways. Okay. One is we either lengthen the word, okay, or we use pauses before and after the word. Okay, who wants to give a try? I can give you a sentence, or maybe I have a picture here that we can practice on. Oh no, we don't have a picture here. Think about these flowers and describe it. And use the acoustic highlighting. Anyone, any brave soul here? Want to try it out? Come on. Just one small sentence.
I'll go.
Oh, please, yes.
Those flowers are so pretty.
Okay. So, what I get an impression of is that you have highlighted 2 words, so and pretty. Okay. So, now how do we make it just on the word so and not pretty?
Those flowers are so pretty.
Can you pause after so a little bit more?
Those flowers are so pretty.
Yes, perfect, right? So that's how you acoustically highlight. Thank you for that. So now acoustically highlighting, of course I as a student, what I learned was I can use a lot of stress pattern. Now, like I said, I'm verbose, but I'm also someone who has a very interesting stress pattern, okay? So all my words get highlighted. So when you say you're using this acoustic highlighting technique, okay. Now what are the rules here? Again, you don't increase the loudness of your voice, okay. Now that is again very counterproductive for the child, okay. You can whisper to the child. Now that is called acoustic low lighting, okay. That also signals to the child that you are trying to emphasize a certain word by telling it a little softer. Anyone wants to try it at a softer tone? Softer loudness? Same sentence you can use.
The flowers are so.
Yes, better, yes. Okay, so good job, thank you so much. So one more other thing that you don't do is you never break the words. Okay, you never break it into syllables because that does not highlight or low light it to the child. Rather what it does is it kind of makes the word like as if it's not together but it's broken up. So you never break it like pretty. So thank you so much for not doing that. Okay, rather you have to have a continuous flow. Okay, no breaking it up into syllables. Right. When you use the talk strategy, you also use the wait strategy, wherein you are giving a moment of silence as soon as you finish talking and you are giving an expectant look at the child. Okay, which that the child has to respond. Now what it also does is it gives time for the child to process information. Okay. These days, what I find with our mobiles and Instagram and YouTube shorts, I find even adults have lost the attention span. I'm including myself in that. I'm no exception to that. In the sense that many often when I'm talking to my colleagues, I find myself repeating the information again and again to them. Especially if I'm kind of telling them, I'm going to go to Nepal and then I'm going to kind of reach the hotel and then I'm going to go for a dinner. They wouldn't have heard the last part. They would have only heard the word Nepal and probably they would have already thought about, oh, how beautiful Nepal is. Okay, it's a nice time to go there, right? So this wait is kind of a time that you allow between these three phrases that I put together, wherein I give time for the other person to process the information, and this applies for the children that we are talking to as well. We're just giving them time to process. Okay. So whenever you find yourself putting like any sentence longer than 4 or 5 words, okay, to the child, remember to use the wait technique. Okay. Is Nepali a fast language compared to say Hindi and English? I find you fast because I don't understand, but this is just a general inquiry. Is it?
I find it faster. Malayalam is faster than Nepali, then I did study during my
Okay. Okay. So I think whenever you think of talking in Nepali, please, this is your go-to technique. Okay, you have to remember to wait and give an expectant look to the child. Right. This is interesting. A lot of people keep asking me about how do we use listening first. Okay, especially in therapy sessions. The logic is very simple. Before we show the object to the child, okay, we talk about it. So if I want to talk about this flower, the child shouldn't have seen this flower. It should be covered. Okay? And then you say, you know what I have? I have a lovely bouquet of flowers in front of me. And then you remove the cloth that's there. So that gets the child to attend to what I'm talking. And then when the child looks at it, there is a connection between what I spoke and what the child is seeing. And the child is paying more attention or efforts to retain it in the child's vocabulary. Okay, so in a therapy setup, I always say have a box that is not that is opaque right next to you, so that the objects that you want to interact with the child you keep inside the box. Okay, talk about it first, not like a research introduction or a research finding kind of a way. Just 2 sentences about the object and then show it to the child. Okay, so right. Also, I think some of the things that I find people doing is that listening first, you call the child's name and you call it listening first. No, the idea is not to get the child's attention when you're using this strategy. The child is to have the child focus attention. The idea is to have the child focus on what you're saying and then showing the object. I think Indians and in Nepalis, I think you kind of have the habit of calling and talking about whatever you want to talk, use their names and talk. So that is not listening first, okay? That is just to get the attention. But when you're having listening first, you need to again wait and then give the information and then show the object that you're talking about, okay? So this is another of my favorite technique, which is a very go-to technique for a new clinician, which is called as the auditory sandwich. What is auditory sandwich? Just like any sandwich that we eat, okay, we sandwich other cues between the audition. Okay, you start with audition and you end with audition. Okay, so say if I want to say the or do a listening first of watch. Okay, you know what I have? I have a watch. Okay, and I'm repeating the word. I have a watch. Okay, and then I say I have a watch in my hand. Okay, and then I say, so I said I have a watch. Okay, so you are making sure the child is not seeing the first time and the last time. In between, you can use any set of cues. You can use visual reminders, you can use even tactile cues or pointing to how you're saying it. You can use any number of cues in between, but you have to finish it with audition. That's the most important thing, right? Okay, so this is something I wanted to know from all of you. Okay, the technique is called auditory hook. Now we want to make listening interesting. Okay, and we want to say something interesting about the object that we want the child to learn about. So instead of saying the name of the object, we use something to get the child's attention. Okay, either I can say, oh, see, I see beautiful flowers. Okay, so when I said, oh, your attention immediately went to my voice, hopefully. Okay, and then you sustain your attention after that. Okay, so auditory hook purpose is this. Can you think of any auditory hooks that you naturally use? I come from Chennai, so obviously the stereotype that I have, which is called the auditory hook stereotype that I have is achacho. Okay, ayo. Okay, and everyone makes fun of us in the other part of the country for this. Okay, so can you think about some auditory hooks like this? These are also what technically we call onomatopoeic words.
Like we say, wow, abhi.
Abhi.
Abhi means like.
Okay. What does abhi mean?
Like
Scary?
Kind of scary.
How do you say it? Can you say it?
Abhi, dog is there. Means they will look at us and they will look to dog. Abhi is like if I'm scared, I can use. But how do you say it as a hook?
How do you? Yeah. How do you? Yeah.
Abhi.
Yeah. Yes. Okay. Any other examples?
Also we use wow.
Wow.
La.
La. Okay.
Like if something for them, ja.
Ja. Okay.
No, fa. Some word.
Okay, so all those are your beautiful auditory hooks that are embedded in your language. Now, there's another thing also. I told you the onomatopoeic words, right? Especially the words that we use to describe animals and objects. Again, from Chennai, Tamil speaking, we have this funny thing with dogs. Okay, the whole part of the country says probably bow bow, but we are the only people who say lol lol. And they'll be like, which dog says lol lol? how can a dog sound lol lol? But that's how it sounds to us, and that's the auditory hook we normally use. So any other animal funny things like this? How do you say dog barks? Not in English, please don't say bow bow.
It's gook also, they say gook also.
Gook, okay. Okay.
Meow meow for dog.
So you should probably get back to your, grandparents' generation, and they might still remember what are those onomatopoeic words that they generally use, and pick out these words and start using with children with cochlear implants to make their life a little bit easy and interesting. Okay. So yes, We have something called as the play sounds that is there on our website that has a list, something, it looks something like this. Okay, these are all probably universal words that we use as auditory hooks in therapy. So you can look at that and use it. And another simple rule is, if you can't think of an auditory hook immediately, just repeat the word twice, the word thrice, and make it interesting with all the up and down sing song pattern that you can incorporate. Okay, and I think say it again is just repeating and rephrasing. I'm going to skip this to take you all to one important strategy in talking. Two important strategies. One is the my voice matters. Now why this is important is because,
Excuse me?
Yes.
I think we are running short of time.
Okay, I'll just wrap up with this. So my voice matters is actually you are giving the impression that whatever the child vocalizes, whatever the child babbles is very important, and you are giving acknowledgement to whatever the child is vocalizing. It may not be meaningful, but it gives a child an idea that it's important for the child, and it's important for you or important for the parents that the child vocalizes and brings some kind of a speech output, right? And maybe I'll just do the auditory closure as a fun activity. Okay, wheels on the bus goes. Yeah, that's auditory closure. Okay, so you just repeat things to the child. Okay, like songs or rhymes that the child is interested in, or any catchphrases that you use in your language, and you incorporate it and you pause and wait for the child to respond to. So that's how it becomes a talking strategy. So with that, thank you so much for the opportunity. If there are any questions, I'm happy to take. Otherwise, I think I'll just leave it there. Any questions? Ma'am, any questions? No. Okay, thank you so much.
Thank you, Shancon, for a very informative knowledge sharing talk on auditory rehabilitation. We really enjoyed your session and learned a lot. Thank you.
With that, we conclude the first guest lecture session. Ma'am, to hand over certificate to speaker Ms. Sabna Fatima. This session will be chaired by Ms. Clarice Warwick, a qualified speech and language therapist from London University in 1987, and she began her career working with children with cerebral palsy in India. She later established an SLT department at Western Regional Hospital, Pokhara, Nepal. Back in the UK, she specialized in early years children with complex needs, pioneering multidisciplinary assessment and intervention services. Passionate about empowering children with complex needs, she continues to support pediatric SLT work in Nepal annually. I would like to invite her to chair and take the stage and introduce our guest speaker for the session.
Professor and Head of Department of Audiology and Speech and Language Pathology at the Merv Institute of Speech and Hearing in Chennai. Welcome. We're really looking forward to hearing you this morning. Dr. Paulina Rokia Catherine is an experienced speech and language pathologist with over 11 years in teaching, research and clinical practice. She's passionate about empowering communication. She has guided students, published research and led parent and professional training programs. A former associate editor of the Journal of Indian Speech and Hearing Association, she continues to inspire excellence in speech and hearing sciences. So we're really looking forward to hearing.
A very good morning to one and all. The topic of my talk is language, speech, swallowing in children with cerebral palsy, integrating SLP care into the MTD framework. This is my content for the presentation today. So we're going to see a small introduction about what cerebral palsy is and how MTD team, multidisciplinary team approach would facilitate improving the child's condition, and dysphagia with respect to dysphagia and CP, speech issues, language issues, and also activities and strategies to improve enhance language and communication. So in my talk, I'll be actually highlighting very important points that we need to incorporate in our assessments and our intervention. The next slide. So cerebral palsy is an umbrella term for a non-progressive disorder that occur in the developing fetal or infant brain, causing permanent motor disability and a lifelong activity limitations. Cerebral palsy affects movement and posture. Cerebral palsy often co-occurs with epilepsy, resulting in the associated condition like behavioral issues, intellectual disability, vision, feeding and hearing impairment. Primitive reflexes may be present and it is strong in them. Again, it's going to really affect the intervention progress. Next slide, please. So prevalence was found to be 2 to 3 in 1,000, and risk factors of CP includes gestational age, prematurity, a low birth weight, and being underweight. Okay, so types of cerebral palsy, main classification include spastic, 70 to 80% are spastic, and then addictoid 10 to 20%, ataxic 5 to 10%, and mixed about 10%. Okay, so in a multidisciplinary team approach, so the pediatrician, SLP, clinical psychologist, special educator, physiotherapist, occupational therapist, and a pediatric neurologist are the very important team members. Okay, so pediatrician, they tell about the medical aspects and the developmental progress of the child. They monitor the developmental progress and inform the other team members. Okay, neurologist, neurological aspects and how they affect speech and motor functions. And OT, they focus on the fine motor skills and sensory motor integration, and also the ALD, that is the activity of daily living, that can impact and support communication, especially the sensory integration processes that they assess and intervene. They are really vital for feeding. Physiotherapists, they focus on the gross motor skills, posture, breath support. Again, it's very important for improving the speech aspects. They are foundational for speech development. And psychologists, they take care of the behavioral, emotional, cognitive challenges that may coexist and impact therapy engagement. And special educators support in learning and academic adaptations related to communication difficulties. So SLP, so we see these three important aspects. Okay, we take care of assessment and intervention. We play a key role in this. Swallowing, receptive language, speech or communication. Moving on to dysphagia and cerebral palsy. Okay, so coming up to the reflexes related to swallow, the routine, reflex, tongue progression, tongue transverse and basic bite, and the gag reflexes. So these reflexes are expected to present certain months, early months in the infant's life, and they need to disappear after that. But in children with cerebral palsy, they persist many times, and this makes it difficult for them to develop more controlled motor skills later. Just a glimpse into the normal swallowing aspects and what is affected, which aspects of swallow that could get affected in cerebral palsy. Okay, so these are the normal phases of swallow. The first one is the oral preparatory phase, where food is taken into the oral cavity, and use of lips and the tongue movement. Okay, food is getting manipulated. We chew the food and make it into a bolus. Okay, and then the oral transport phase. From the anterior part of the oral cavity, the food gets back to the back of the oral cavity. Okay, this is mainly done by the tongue elevation. So, oral preparatory and the oral transport phases. So, with respect to cerebral palsy, okay, it's going to be very tough for the children, many children with cerebral palsy. Okay, to have a good lip closure. Okay, since lip closure is not good in them, they might have anterior spillage of the foot. Okay, and because lateral movement, the tongue, there's a limitation in the tongue movement. The lateral movement of the tongue gets affected, and they will not be able to take the foot from the center part of the tongue to the molars for chewing. And after chewing also, they have great difficulty in bringing it back to the center part of the mouth. And many times we can see some of the children with cerebral palsy putting their hand to bring it back to the center part of the oral cavity. Okay. And again, the tongue elevation could also be limited. So this will create a great challenge for them to take the foot back to the back of the tongue. Okay. Then the next phase is the pharyngeal phase. It's a very complex phase. The swallow reflex happen in the pharyngeal phase. It requires greater coordination of back of the tongue, posterior pharyngeal wall, soft palate, and it also very importantly requires laryngeal elevation and vocal fold closure. Okay, so these are very important things. So here also that could be a delay in initiating this pharyngeal phase in many children with dysphagia and cerebral palsy. And the last phase is esophageal phase, wherein the food is getting pushed into the upper esophageal sphincter. The upper esophageal sphincter opens up. There is a great difficulty in children with cerebral palsy. Cerebral palsy and dysphagia, brain damage from CP affects neural pathways leading to poor tongue function, delayed swallow initiation and difficulty controlling oral pharyngeal muscles. Dysphagia is common in children with cerebral palsy. Okay, so in a study of 122 children with cerebral palsy between 18 to 36 months of age, it revealed that about 85% of children had dysphagia, and dysphagia increases. It also found that with greater motor impairment, the number of individuals having dysphagia is also higher. Okay, and also spastic quadriplegia. Okay, sensory motor impairment. Many times we think cerebral palsy is motor impairment. Yes, it is, but many of children with cerebral palsy do have sensory issues as well. Okay, and also it makes it complex with respect to their cognitive impairments and communication deficits. When they are higher, there's many children with such problems also have swallowing issues. So cerebral palsy, children are at risk of aspiration with oral feeding. So they might have repeated lung infections, pulmonary consequences. Okay. Another thing is, since they have difficulty in their swallow movements, they might take very less food. Okay, so reduced nutrition and hydration status. They also have drooling. So with drooling they lose a lot of salivary secretions, and that can dehydrate them as well. The meal time is prolonged and stressful. They might also have gastrointestinal issues and oral sensory motor deficits. Okay, all these are due to reduced lip closure, poor tongue function, tongue thrust, exaggerated bite reflex, tactile hypersensitivity, delayed swallow initiation, reduced pharyngeal motility, and drooling. Okay, these are the oropharyngeal problems that they could have. So especially if you see children with cerebral palsy, in my experience with children with multiple disability and cerebral palsy, I have seen children, I never seen a child who is obese, a child with cerebral palsy who is obese. Most of the children are thin, and if you see, they will have the incisors would be actually protruding for them, many of them. Okay, that is mainly because of tongue thrust. Okay, they place the tongue, so it's actually a reflex. It has to get vanished, but for them it retains, and because they place their tongue anteriorly, the incisors gets protruded, the upper incisors get protruded. So next time when you see a CP child, you should definitely observe for that. Okay, so problems with liquids, mainly it's because of timing deficits with delayed pharyngeal swallow initiation, and problems with smooth, lumpy mashed foods relate to residue in the pharynx when pharyngeal motility is reduced. So residue can spill into the open airway after these swallows. Okay, so the red flags for dysphagia in CP children, these are the things we need to definitely ask the parents and we need to observe. Children with CP frequently need more time to complete the feeding task, longer than 30 minutes on a regular basis, and lack of weight gain over 2 to 3 months, and increased congestion at meal times, gurgly voice generally after a swallow, frequent respiratory illness, delayed progression of oral feeding skills. Okay, and another thing is risk of aspiration can decrease with developmental gains as the child grows. Okay, risk of aspiration could get decreased, and increased signs of dysphagia as children reach puberty is also present in some clients. Okay, it could be because at that time the nutritional need is more and children might develop kyphosis and scoliosis. So they might seem to have more dysphagia, more issues with swallowing then. Okay, so moving on to the clinical feeding evaluation, some important points I would like to share. Okay, so observe children at meal times. Both sensory and motor deficits could occur in the child. Okay, mixed texture could be more difficult for them, especially soups where we have solid, semi-solid and small bits of different textured materials in the soup. Okay. Children with primarily motor motor problems, okay, so they might have motor problems or sensory problems. Okay, if it is mainly the motor issues, then these kind of symptoms they could exhibit. They might be unable to hold and manipulate the food on the tongue. Okay, therefore anti-spillage could be present, and vomiting is not texture specific. Any food they would vomit because of motor issues. But if the sensory issues, due to sensory issues, they might hold the food under the tongue to avoid swallowing. They are likely to vomit only on the certain textures and will not accept oral stimulation like brushing. They will not allow others to do, and often reject toothbrushing. Yes. Okay. Instrumental evaluation. So we can give food trials to these children with different consistency like water, semi-solid and solids. We can try in small amounts like 3 ml, 5 ml. We can try of these food in our clinical routines. But to make it more, to get a conclusive decision on whether a child should go for oral feeding or the child should go for tube feeding, we definitely need to rely on instrumental evaluation. So video fluoroscopic study and fees examination are recommended for children to make such decisions, because not only this type of instrumental evaluations are getting more and more available for children to access, and I've seen many children, though they have severe dysphagia, parents, they really want children to have oral feeds. They don't want their children to have tube feeding or the peg tube to be inserted on their stomach. They want their child to feed, to keep the food through the mouth. So it has created a lot of children. We lost lots of children in the clinical practice because of their oral feeds. They have severe aspiration. Sometimes aspiration could be silent and it is more dangerous. So definitely we have to go for instrumental evaluation and take appropriate measure, because for us maintaining good nutrition and also the child's growth, overall child's growth is very, very crucial. So we need to rely on the instrumental evaluations, and to, as a team with the dietitian, radiologist, neurologist, the final conclusion on oral feeding or tube feeding to be made and to support the children. Okay, so management decision making must take into account of interrelated factors and not simply therapeutic programs to advance oral skills. Factors that may have a negative impact include fatigue, lethargy, and seizure disorder. Individual decision making with close monitoring over time is critical as children show signs changes in oral skills and safety of swallowing. Appropriate posture to be maintained during feeding. Okay, so this is a good posture with good backrest and foot rested. So almost it is in the 90-degree angle. Okay, you can see the knee bend and the ankle bend and the back support. It should be at this. This is a very ideal posture where they may not have aspiration. So during feeding time, this needs to be practiced, and this posture will also help them to be more stable even during therapy. When we give therapy also, speech and language therapy. Okay, so management, some very important points. We need to focus on the stable airway with adequate nutrition and hydration. And any feeding and swallowing intervention should be pleasurable and non-stressful to patients and caregivers. Tube feeding may be needed and either temporarily or for a long term. Gastrostomy tube feedings may improve growth, especially with severely affected gross motor function and those children who have had poor weight gain along with their severe feeding and swallowing problems. Okay, so we need to have dietitian as a part of dysphagia treatment to give adequate, to make sure the child could take the right consistency of food with good nutrition as well. Okay, so, and another very important thing, so we make the child to take part in the family meal times, not to fed separately. The child, along with other family members, we should recommend the parents to feed the child and to consider the sensory issues and plan further. Yeah. So, non-nutritive opportunities also to be given are thought to facilitate oral feeding skills, for example, sucking opportunities for preterm infants, most often via pacifiers. So, it will allow them to develop the motor skills for feeding too. So, this needs to be definitely tried. Okay. And also, even for older children, okay, with severe dysphagia, severe issues with motor movements of the oral cavity, okay, we need, very important to try, okay, small amount of foods, okay, so to put their fingers into the food and suck on their fingers with a minuscule amount of food on them. So positive impact on management of saliva secretions while maintaining oral function and swallowing. So it is recommended even the children with severe dysphagia, but under supervision can be tried. Okay, so children can generally accept 2 to 3 drops of water via spoon, though they are in the tube feeding. Children receiving nutrition and hydration via tube feeds should be appropriate for brief taste sensations over 2 to 3 minutes multiple times per day. Okay, so opportunities for production for purposeful swallows are important for oral skill development and for pleasure. Okay, so regular and thorough oral care is also vital, so that needs to be monitored. All of these children need validation. These studies need validation with systematic data collection. Still more research is required in this. Okay, so here they say like strengthening exercises in the study. They mentioned that strengthening exercises does not improve the child's condition. Okay, so that should not be tried. Even in odomotor exercises, we do a lot of strengthening exercises. So that may not work with children with cerebral palsy. So more evidence is required. So disaster impact include shallow, irregular breathing for speech, low pitch, harsh voice, reduced pitch variation, and unexpected pitch break, hypernasality, articulation. These are generally seen in children. Okay, so the studies indicates that therapy, especially for mild issues, moderate to mild dysarthria, would improve their speech clarity. But there is no research evidence that oromotor therapy to increase control of non-speech. Okay, so next is language issues in CP. So generally, their receptive language, if their cognitive abilities, issues with receptive language, so because of motor impairments, so the expressive language, the language, there could be a great delay. So in such instances, we need to go for alternative augmentative communication, and it can be started as early as possible. Okay, we need not wait for a trial therapy. Okay, especially for assessment. So maybe multiple picture choice based assessment could help them. Okay, so such modification assessment session could help them. And also we need to think about the fatigue the child could have. So a longer session may not be very good for them. Short sessions could help them better. Okay, so some of the strategies to improve communication: observe, wait and listen to the child's communication efforts, that's very important, and creating opportunities for the child to communicate whenever it is possible is really therapy needs to be done, and sharing books could enhance language and communication. Using rhymes and music in a creative way in the sessions is going to really help the child to improve their comprehension and expressive skills. Okay, so as I said, AAC we need to implement as early as possible with children with cerebral palsy. Okay, so especially switch modification might be required since they have motor issues. And take home message. So understand the roles in MDD framework and work together for the maximum benefit and growth of the client. It's crucial to make timely decision on oral and non-oral feeding for children with cerebral palsy. Stable airway and adequate nutrition and hydration is the target. No evidence for oral motor exercises to improve their speech or feeding skills.
Thank you very much. Incredibly comprehensive covering of cerebral palsy, and it's a passion of mine, so it's really lovely to hear it delivered so well and so comprehensively. Thank you. Does anybody have any questions? Yeah.
We see a lot of these days commercially available programs like oral replacement therapy of top tools, where based on the assumption of, they say, grading and dissociation. Do you find that assumptions valid, and do you think it works, or will we be losing our opportunity cost that we would use for AAC if we use such assumptions? What is your...
So it really works when children have motor planning deficits. For such children it would definitely work. So that is what I get from what I've learned from OPT. But AAC, as early as possible, we need to implement it. So either it's going to augment or could be an alternative if speech is not developing. So we need to view it in that way. So it is augmentative, so definitely we need to use AAC along with all other interventions.
One more question. I just saw your content of hand,
and perspective on such an important area of clinical practice. And heartfelt thanks to Miss Clary for chairing this enlightening session, and we would like to call you to hand over the